Without further ado, we might kick things off, and I'll introduce our presenter for today, Dr. Jason Butler. Dr. Butler is a clinical haematologist at the Royal Brisbane Hospital, and he's also recently started consulting at IgM Chermside in South Brisbane. Some of you might have even seen him in person at one of our seminars. He was here only recently to present a Waldenstrom's topic. So I might hand over to Dr. Butler now and enjoy the webinar, guys.
All right, thank you, Ali. So this is the first occasion I've ever done one of these webinar talks, so I also feel like I'm a little bit of a guinea pig at the moment. So hopefully everybody bears with me. I must say it's a little bit unusual not having an audience sitting there in front of me, but something I'll get used to over hopefully the future of doing these presentations. So what I've been asked to talk about today is looking at understanding in particular the blood results and trying to put into context the reason why we do the blood tests that we do in Waldenstrom's lymphoma, and how those blood tests then can perhaps influence the decision making we make about the treatment and the ongoing sort of follow-up for Waldenstrom's. Now, Waldenstrom's, because it is a type of lymphoma, is a disorder where the blood tests form only one part of the testing that we do. But what's a little bit unusual about Waldenstrom's is probably that the blood tests are the most important of all the tests that we do. And that's a little bit different from other types of lymphomas and leukemias, where the blood tests probably only form a fairly small part of the investigations that we do. So there are a number of other tests that will be done routinely in Waldenstrom's, particularly when you first turn up. As mentioned, that includes the blood test, but also a bone marrow test. One of the natures of Waldenstrom's as a disease is that it is one that is really predominantly found only in the bone marrow. And generally disease outside the bone marrow is not typically present in very great amounts. We will also do CT scans, looking particularly at the size of lymph nodes and to see where there might be areas of enlarged lymph node groups, but also looking at the spleen and also in particular the lungs to see whether there might be evidence of involvement with the Waldenstrom's in the lungs. But again, as mentioned, unlike most other types of lymphomas, the lymph nodes often don't show too much in the way of change, which is unusual for a disorder that is typically one of the lymphatic system. Now, PET scans may be something that gets ordered by the haematologist who looks after you, but really the evidence for use of PET scans in the more indolent or slow-growing types of lymphomas like Waldenstrom's is not terribly great. And there's certainly investigations that are mainly done in people who have the more aggressive types of lymphoma. Now, in terms of the blood tests, what are the important ones that we do? Now, probably the most important test that guides us in terms of what the disease is doing, and perhaps is the one that is best used to work out whether treatment is necessary, is this thing called the electrophoresis of the serum proteins, or Serum EPP, or protein EPP. It has a number of different names. And I'll spend quite a bit of the time during this talk actually talking about how that test is done and what the results mean. Other important investigations we do include a full blood examination, or FBE. Sometimes it's called a full blood count, or FBC, but all of my pathology colleagues constantly remind me, in fact, that there's more to that particular test than just simply counting the blood cells. One of the important things that will happen with any full blood examination that we do is one of the technicians or scientists in the laboratory will have a look down the microscope at your blood film to see whether there's any changes that they can see looking down the microscope. The other standard test that gets done pretty much every time you have a blood test is a measure of the electrolytes or minerals and the kidney and liver function test. And once again, the name of this test varies from lab to lab. We tend to call it the ELFTs here at the Royal Brisbane Hospital, but other test terminologies would include a Chem20 or a SMAC or the UNEs. I'll talk very briefly about a couple of other tests that are typically done at diagnosis, which is flow cytometry, and also just briefly about another test called plasma viscosity, which isn't done as often as it used to. So this is an example of what Waldenstrom's lymphoma may look like looking down the microscope at a bone marrow sample. So the top slide shows 3 different arrows, a white arrow, a black arrow, and then a grey arrow. The white arrow points to what would be considered a fairly typical looking lymphocyte. The purple that makes up most of that cell is the nucleus, and there's a tiny amount of blue cytoplasm around that particular cell. The grey arrow points to what is one of the hallmarks of Waldenström's, and that's an abnormal looking lymphocyte. It's a lymphocyte that actually looks very much like a plasma cell, which is the abnormal cell that we see most often in a different disorder called myeloma. And the black arrow points to what is a more typical looking plasma cell, and that's certainly, again, one of the hallmarks of Waldenström's is you have these many different types of cells that are visible when you look down the microscope. Most other types of lymphomas, the cells that are the malignant cells or bad cells, all tend to look roughly the same. The bottom slide, slide B, is actually what the biopsy bit of the bone marrow might look like. And all the little black cells are all individual plasmacytoid lymphoma cells. So, and the big white sort of dots, fat globules, which are normally seen in the bone marrow. So that's an abnormal looking bone marrow, and that's a bone marrow that has Waldenström's lymphoma. Now, one of the tricky things is that the definitions of Waldenström's macroglobulinemia has been changing over time. Basically, it's a form of a disorder called lymphoplasmacytic lymphoma, or LPL. So Waldenström's is, as I say, it's a subset of that disease. Now, it's the subset of that disease where patients' lymphoma cells make a protein called IgM Paraprotein. There are other forms of LPL where the paraprotein that is made is not the IgM subtype. And so technically speaking, that's not a type of Waldenström's, even though it is lymphoplasmacytic lymphoma. So, but Waldenström's will make up about 90% of all of the types of LPL that we see. I mentioned earlier on one of the slides is that Waldenström's a fairly peculiar type of lymphoma. It is quite different to the way that other lymphomas behave. Importantly, it's a type of lymphoma that is mainly found only in the bone marrow. And in fact, in the majority of patients, when they turn up, the bone marrow is the only place where you can find evidence of disease. Occasionally, you can get evidence of the disease in the lymph glands, the liver or the spleen, but that, as I say, is relatively unusual. And that's quite distinct from other types of lymphomas that we see, which are mainly involving the lymph glands. The types of treatments that we need to use for Waldenström's are somewhat different to what we use in other types of lymphomas. Vincristine, for example, is a chemotherapy drug that we tend to use in virtually all of the lymphomas that we see. But in fact, in Waldenström's, it probably has one of the least effects of any of the lymphomas out there. Now, we often still do use vincristine because probably in many patients it will have something of an effect, but certainly less so than we see in other types of lymphomas. One of the other interesting things is that the types of treatment that we use in another disease called myeloma seem to also have effectiveness in Waldenström's. And that probably reflects the fact that myeloma is a tumor of plasma cells, and Waldenström's has plasma cell-like features to it, and that's probably the reason why these types of treatments work in both diseases. The other important feature is this excess of protein that is produced by the lymphoma cells. And why that becomes important is that it actually provides probably the best method of monitoring the disease. The level of protein in the blood gives you the best overall picture of how the disease is behaving. Now, there are other types of lymphomas that also have this M protein that is found in the blood, but it tends not to be to the same level or extent that we see in Waldenström's. The level of that protein tends to be much higher. Now, I mentioned before about the importance of the blood test and how in Waldenström's it's much higher than we see in other types of disorders. Now, with all of the diseases that we look after, when patients come through the door, one of the things that we have to work out is what their prognosis is. So essentially, what prognosis means is working out what perhaps the average life expectancy for that patient is, but also how likely it is that that patient will respond to the standard treatment. Now, in Waldenström's, this is an example of one of the most common prognostic scores we use. Now, age pretty much is always a factor in the diseases that we look after. So unfortunately, as we get older, our age tends to count against us, both in terms of our ability to tolerate treatments. But it also seems that as we get older, the diseases behave in a more aggressive manner and don't respond to treatment as well as they do when we're younger. And a lot of the reasons behind that aren't entirely clear. The next four factors on this particular slide are all things that are measured from blood tests. So hemoglobin or red cell count, the platelet count, another thing called the beta-2 microglobulin, which I'll come to a little bit later on, and then that serum paraprotein level that I've been talking a bit about. And the levels of those blood tests actually, if you fall within the range mentioned here, counts as a bad feature in your particular disease. And when you add up all those points together, it enables us to come up with a prognostic score, which can help predict for how we expect people to go with the treatment. And you can see here that if you have one or less of those factors that we mentioned before, excluding age, then you have a 5-year survival rate of approaching 90%. But when you have 3 or more of those risk factors mentioned on the previous slide, your chances of being still alive at 5 years drops quite substantially. And that's a rather chilling statistic there, that very last number, to see such a small proportion of patients in that high-risk group being alive at 5 years. And so what that tells us is perhaps that if you turn up in that particular risk group, it might mean that we need to look at perhaps more intensive treatment to try to improve that overall outcome. So what it means is those blood test results have critical importance, not just for working out whether you need treatment, but what the probability of responding to that treatment would be. So I keep mentioning this monoclonal protein or M protein, and as I say, it's probably the single most important thing that we measure in Waldenström's. It has lots of different names. The other two that are well known about are paraprotein level or monoclonal gammopathy. And what this particular protein is, essentially it is large quantities of abnormal antibodies being produced by the lymphoma cells inside the bone marrow. So normal healthy B cells make antibodies. And essentially because Waldenström's is a tumour of B cells, the abnormal cells are producing abnormal amounts of antibodies that can be detected as this M protein. And as said, we measure this particular M protein using this technique called electrophoresis and another secondary technique called immunofixation. Now this is what an antibody looks like. So this is the thing that we're measuring when we measure normal antibody levels, but also when we're measuring the protein level in Waldenström's. And a normal antibody is made up of a heavy chain that is bound to a light chain. And the way that we describe antibodies is based on the characteristics of that heavy and light chain. There's 5 main types of heavy chain, ranging from IgG, A, M, D, and E. And as mentioned before in Waldenström's, the type of heavy chain is IgM. But the light chain, there's one of 2 different types. There is kappa and lambda. And in most people with Waldenström's, the light chain type is kappa. So that means we would describe the M protein that we find in most people as IgM kappa. Now, one of the peculiar things about IgM is that it doesn't exist as one single molecule. What actually happens is 5 IgM molecules all join together and form these things called pentamers. And what that means is this structure, these 5 IgM molecules joined together, is a very large molecule. And it's that very large size that contributes to a lot of the problems that we see with the Waldenström's protein. Because of its very large size, when it's present in relatively large amounts, it causes a problem where the blood becomes too thick or viscous. And this is what we refer to as hyperviscosity. And one of the more common reasons why people might first present with Waldenström's is because of signs of sluggish blood flow due to the increased viscosity of the blood. In some people, in the extremities, like in the fingers or the toes, that protein can actually precipitate out and cause a jelly-like substance in the blood. And this is a thing called Cryoglobulinemia, so meaning that at very cold temperatures, the protein precipitates. The protein itself can also interact with some of the healthy proteins in the body, particularly some of those that help the blood clot when it needs to. And that interference can then lead to those clotting factors not working properly and increasing the risk of bruising, bleeding, or even more severely when you get hemorrhage. The antibody itself can also have activity. So, for example, it can bind to the nerve endings and cause inflammation, or a neuropathy as we call it. It can also, for example, bind to proteins on the outside of red cells and lead to destruction of the red cells, a thing called cold-type hemolysis. The other thing that the protein can do, it can actually deposit itself in the organ. So rather than staying within the blood, as it goes, for example, through the kidneys, it can get out of the blood and deposit itself in the kidneys, leading to destruction of the kidney function. It can also join together and cause this protein called amyloid, which can also cause problems with function of normal healthy organs. Now, the EPP is performed by the scientists in the pathology lab. And how do they do that? Basically, they take some of your blood and they separate the serum out from that particular blood, and then they put the serum into a well, which is then placed on a gel-like structure. And what they actually then do is they apply an electric charge to that gel. Now, what happens when you apply electric charge to proteins? The proteins basically move. And every different protein in the body has slightly different characteristics. So they move a slightly different distance away from where they started. And then basically what the scientists can do, they can stain up the proteins on the gel, and then you get a electrophoresis gel like is seen on this particular slide here. So each of those little strips represents a electrophoresis from an individual patient. So I think there's 39 different patient serum electrophoresis on this particular gel. And each of the dark strips, the dark bands that you can see on the strip, represents a different type of protein. Now, what they can then do is they can then map out all those individual proteins, and they are basically then grouped based on their electrical functions. So, for example, the darkest strip here is albumin. Albumin is the most frequent protein that we see in the blood. And then you have the alpha-1 proteins, the alpha-2 proteins, which are red, the beta-1 and beta-2 proteins, which are green and pink down here, and then finally the gamma proteins, which are the brown ones. Now, for most people, the paraprotein that we see in Waldenström's runs in the gamma region, so down in this area here. Occasionally, in some of the other lymphomas that we see that produce the M protein, the protein runs in the beta section up here, so it runs in a slightly different area. So what we actually see, so this is what a normal electrophoresis looks like. So you get the very high levels of albumin and relatively small amounts of the other types of protein that we saw on the previous slide. However, in Waldenström's, you get a very large production of in the gamma region, which is that abnormal M protein produced by those the abnormal cells inside the bone marrow. The second part to the test is called immunofixation, is where they work out the type of heavy chain and type of light chain. So, for example, I didn't have one that was specific for Waldenström's, but this is an example of what we see in myeloma. So again, this patient here has a type of IgG heavy chain and has a kappa light chain. So this individual person has an IgG kappa paraprotein. This patient over here has the same one. So again, has a dark band in the IgG and in the kappa. Whereas when we come up to this one, serum 4, this person again has the IgG heavy chain, but the light chain this time is lambda. So in a patient with Waldenström's, we would not see this band over the IgG region. We would see it in the IgM region instead. So by the end of this testing, where the pathologist has done the serum EPP and the immunofixation, they actually can tell you the type of paraprotein that you have and also how much of that paraprotein is there. And so this is an example of what we receive when we order a serum EPP, where, again, they basically provide us with all of that information we saw. So they tell us about how much albumin, the alpha-1, alpha-2, beta, gamma, and then finally this bit here, which I'll now highlight, is the IgM kappa paraprotein. So that's the M protein that we're using to measure in this particular patient. And so you can see here in 13th of November 2013, the level was 21. And this particular patient then started on chemotherapy, and you can see over time that the paraprotein comes down slowly each time that we see that particular patient. So that's the test that we use to get the best sort of overall picture for what the Waldenström's is doing. And so in this case, the patient appears to be responding quite nicely to chemotherapy because the paraprotein level is moving back towards 0. Now, the question that is often asked is there a particular level of this abnormal protein that's significant? And unfortunately, the answer to that question is no, not really. And that at the end of the day, the best way of working out for an individual patient whether they might need treatment or not is really based on what symptoms they have and what we find on examination. Generally, for me, I find that for most of my patients, once that level gets up to 20 or greater, that patients will actually have symptoms attributable to their protein. And most often that will be the symptoms of sluggish blood flow, which might be tiredness, fatigue, or things like headaches, which they hadn't had beforehand. As I mentioned before, I believe that really this paraprotein level is the best guide to monitor treatment. Bone marrow tests can be relatively useful, but one of the problems with bone marrows is you're really just sampling the tiny bit of bone marrow on the end of the needle, whereas the protein level in the blood gives you the overall picture of what the disease is doing. And obviously it's a far less invasive method of monitoring what the disease is doing. Now, one of the other interesting things is since MabThera or rituximab started to be used in this particular disease going back 5 to 10 years ago, we started to see some strange things. And one of these things was that in many patients when they first get their rituximab, we actually see quite a significant jump or increase in the paraprotein level through the first 1 to 3 cycles. And that was, we probably now know that that's due to the rituximab binding to the lymphoma cells. And as the cells die very rapidly in response to the rituximab, it leads to a massive outpouring of the protein that was stored up inside the lymphoma cells. Now, why that's important is if you do get this very large jump in the paraprotein, it can lead to exacerbation of the symptoms or, in fact, lead to life-threatening complications. And it's one of the reasons why sometimes what we do is we actually don't give rituximab during the first 1 to 2 cycles, allow the chemotherapy to knock the disease down a bit before we introduce the rituximab a little bit later on into the disease course. The other thing that some hematologists will do is when they're worried about the potential for this flare is to actually start some plasma exchange treatment at the same time. With that plasma exchange can actually help reduce the protein in the blood quickly and prevent any side effects from a jump in the levels. Now, the other thing that is a little bit strange since we started using is MabThera is even after the treatment's finished, we often see the levels of the protein in the blood continuing to go down for 3 to 6 months after the end of the treatment. And that's not something that we've seen with any of the more standard treatments that we've used in the past. Now, I mentioned this old-fashioned test called a plasma or the serum viscosity and how we don't tend to use it very much anymore. It's still available, but as I said, really its relevance has been called into question, and particularly now that we have the paraprotein levels which are very accurate and we use patient symptoms as the best guide, there's not a lot of really good reasons for measuring people's plasma viscosity these days. The levels do vary significantly from patient to patient, so you really can't compare the level in one patient to another patient. It's actually not a very difficult test to perform, even though I've written that there. It's just a little bit annoying test to actually perform. And essentially what happens is they put a little bit of your serum into a tube, a tiny little capillary tube, and then actually turn it up, and they measure the rate at which the blood moves down the capillary tube under the effect of gravity. So basically the longer it takes to drop through the tube, the more viscous the blood is, and that's how they determine the actual viscosity. Now, one of the problems is that there's lots of different things that can cause the plasma viscosity to go up, and most commonly that's inflammations. So any type of inflammation inside the body, for example, inflammation due to a cold or a flu, inflammation due to chronic inflammatory disorders like rheumatoid arthritis. Any of those things can increase the plasma viscosity. So it's not a very specific measure of what the Waldenström's is doing. And these days, in fact, there's this other test called the ESR, or erythrocyte sedimentation rate, that's largely supplanted the use of serum viscosity as a measure of inflammation. The other thing that I said before, I said that how it varies from patient to patient. It also doesn't really correlate very well with what the paraprotein level in the blood is, or symptoms for that matter, from patient to patient. But having said that, quite strangely, what we do see is in individual patients, sometimes there does appear to be a threshold level of viscosity, which once the blood gets to that particular level of thickness, symptoms appear. So occasionally there are patients where the viscosity can be quite a useful test to guide when treatment might need to be started. So this is what a full blood count analyzer looks like. That's when it's open and all the mechanics on the inside. Sort of looks like your average family car these days. Now the full blood count, as I said before, is probably one of the other most important tests that we do. And it can be important when you first turn up because, as I mentioned, the number of red cells or hemoglobin in the blood is one of the important measures of prognosis at the very start of treatment. But there's lots of other things that we can use a full blood count for. So first of all, it can tell us whether there's been a change in the number of cells. Most typically that would be because the counts are low, and that might be due to the disease itself. The blood counts are made in the bone marrow, and if there's a lot of Waldenström's lymphoma in the bone marrow, there may not be enough space for the normal healthy cells to be produced, and as a consequence the blood counts can be low. But also therapy, the type of chemotherapies that we use can sometimes lead to a reduction in blood counts, and monitoring of the blood count is very important for anybody undergoing chemotherapy. In some patients with Waldenström's, you will actually have the lymphoma cells circulating around in the blood itself. Therefore, we can see an increase in the number of lymphocytes in the peripheral blood in those patients. When the scientists look down the microscope, they can tell us whether there appears to be any change in the size of the cells. Sometimes chemotherapy can make the normal healthy cells look unusual, and that can be important because sometimes that might mean that we're perhaps overdoing the treatment a little bit and we're starting to have effects on the normal healthy production of the cells in the bone marrow. As the bone marrow recovers from the effects of chemotherapy, it often releases very early cells, so cells that we wouldn't normally see in the blood floating around. Normally in the bone marrow, the cells undergo a very orderly production process from the very basic stem cells through to the healthy mature cells that end up in the blood. But when the bone marrow is recovering from things like chemotherapy, it sometimes releases the cells earlier into the blood to help compensate for the damage that we've done. As I mentioned before, the main reason we would see low blood counts is because there's a problem with the production of the cells in the marrow, and that might be due to the chemotherapy or due to the presence of the lymphoma in the bone marrow, preventing the normal healthy cells from being produced. But the other reason why you can have low blood counts is if something is destroying those counts in the circulation. And that can be the case if, for example, you have a large spleen. So the spleen is a very important organ that sits under the rib cage on the left-hand side. There's lots of things, but one of the important things it does is it filters the blood, gets rid of things that it believes shouldn't be there. And on occasions, when the spleen is larger than it should be, it becomes too aggressive at filtering things out, and it can filter out things that are meant to be there, like the good healthy blood counts. The second thing that can happen is the Waldenström cells can actually produce antibodies that attack and destroy the blood cells. So basically you get an autoimmune attack or an immune attack directed against your own healthy blood cells. And this is an example of what a full blood count looks like. Again, this is the one that type of full blood count result that we see at the Royal Brisbane Hospital. There's a number of different things that this blood count tells us. One example here, if you look at the total white cell count on the 7th of April, it is 5.6. Down below that, they've got these 5 types of white cells: neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And when you add those 5 numbers together, it adds up to that 5.6. In a normal healthy person, about 75 to 80% of the white cells will be the neutrophils. The neutrophils are like the flying squad of the white cells. They're the things that arrive on the scene first to help mop up any bacteria. And that's one of the reasons we worry about infection, in patients who are neutropenic or have a low white cell or low neutrophil count. The other things on this blood test, so the hemoglobin, that's the way that we measure the red cells. We don't talk about red cell count as such. We essentially ignore that result, but we monitor the hemoglobin. Hemoglobin is actually the protein pigment found on the inside of the red cells that helps carry the oxygen around the body. The hematocrit is another way of monitoring the red cells. That is a percentage, and it's how much of the blood itself is made up of red cells. So a number of 0.41 means that 41% of the blood in this particular day is actually red cells. We tend not to use the hematocrit in Waldenström's all that often. The other important test, just to mention here, is this thing called the MCV, which is the mean corpuscular volume. What that is actually a measure of how large your red cells are. Now, most of the time in Waldenström's that will be normal, but some of the chemotherapies we use can cause the red cell size in particular to increase. So it's not uncommon to see the MCV going above normal. Now, this is the third most important test that we were talking about, and this is the biochemistry, or ELFTs. And again, it's essentially a measure of the minerals like the sodium, potassium, bicarbonate, and those type of things, but also a measure of the kidney function, which are those 4 results there, but also the liver function. Again, kidney and liver have no one single test that we look at to measure their function. There's several different ways that we can look at it, and we put all of that information together to get an overall feeling for how the kidney and liver function tests are going. So when we look at the biochemistry test, we're in particular looking for any evidence of abnormal kidney or liver function. And essentially in patients with Waldenström's, there's a number of reasons why either the kidney or the liver may run into problems. Again, it may be due to the sluggish blood flow due to hyperviscosity. It may be due to the aggregation of the Waldenström's protein and those aggregates depositing into the liver or kidneys and causing damage. Sometimes in lymphomas we see high calcium levels, again, which can cause problems with the kidneys. Very occasionally, if you do have enlarged lymph nodes, those lymph nodes can actually block the outflow from the kidney or the liver, and that can then cause backflow damage to the kidney or liver. So lots of different reasons. So if we see somebody with abnormal kidney or liver function test, we then have to spend some time trying to work out what the cause of that is so that we can help fix it. Now, I mentioned that back on the blood test here, right down the bottom, is this test called the lactate dehydrogenase, or LDH. Now, LDH can be an important test in many patients with lymphoma. It is often elevated at the time when you first turn up. And again, sometimes we can use the LDH as a measure of whether the disease is responding or not. So if it's abnormal and it's felt to be due to the Waldenström's, we should see it normalize as the disease comes under control. One of the problems with LDH, like a lot of the other blood tests that we do, LDH doesn't just come from the lymphoma cells, it comes from lots of different healthy cells in the blood. So an abnormal LDH does not necessarily result from the Waldenström's. It could be due to problems with any of the other different types of cell lines in the body. Now, the flow cytometry is a test that we sometimes do when you first walk through the door. The reason is that this is the particular test that we can use to help work out whether the abnormal lymphocytes that we're looking at down the microscope actually represent a type of lymphoma, or they may be reactive lymphocytes. So the type of lymphocytes we often see in response to things like viral infections. And there's 2 different things they can do with this thing called flow cytometry. One thing is they can sort of, they basically run the cells through a machine. They can shine a light through the cells, and then they can see how much that light gets scattered. So there's a couple of different detectors they have, one in front of the machine and the other at right angles. And the second thing, they can use very special antibodies that have fluorescent markers attached to them to see whether there's specific markers on the outside of the cells. So this is what a flow cytometer looks at, and that's one of the scientists looking at some of the flow cytometry results. This is the insides and working of a flow cytometer. So basically the cells pass through this particular thing here, and essentially a beam of light then is shone through the cells, and then how much the cells scatter that light is determine some of the important properties of that cell. And then also, as I said, they can use some special fluorescent markers to see what proteins are found on the outside of the cell. I'll just skip through the next couple of slides and just come to, these are some of the markers that are found on normal healthy B cells. So there's a CD10, CD19, 20, 22, 23. Now, in Waldenström's in particular, you will see all of the cells will have these three main markers, 19, 20, and 22, as well as that thing down the bottom there called surface immunoglobulin. So again, the scientists can use this bit of information to prove that those lymphoma cells are B cells, and if they all look like they're very similar to each other, then that helps the scientists tell us that this is a type of lymphoma. Now, the very final blood test that I wanted to mention is this thing called the beta-2 microglobulin. And I mentioned that because we brought it up in one of the earlier slides about its role in prognosis. Now, again, beta-2 microglobulin is a normal protein found in normal healthy cells. If anybody there has ever had their tissue typing done to look to see whether there was a donor who might be suitable for a donor transplant, beta-2 microglobulin is one of the tissue typing proteins. Now again, most commonly if beta-2 microglobulin is elevated, it's elevated because of a benign disorder. So we often see this particular protein elevated in diseases of the kidneys or the liver. But in many lymphomas, beta-2 microglobulin can also be increased. And generally, if it is increased, how much it's increased can be an important determinant of prognosis. What we typically see is that the higher the level is, the worse we tend to see the diseases behave. And it's probably a fact that this particular protein reflects how rapidly the disease is turning over. And in general, in a disease like Waldenström's, if it's behaving more aggressively, then that tends to indicate that it's going to be a very nasty form of the disease. The very final slide just to talk about is I mentioned when I gave this talk at the live at the Luke Foundation that this was a particular bugbear of mine, but just to make the point that when we think about Waldenström's as a disease, it is a type of lymphoma, and really at the end of the day, the protein that we see is a reflection of that underlying lymphoma. Now, the protein itself is a symptom. The lymphoma is the cause. And one of the things about treatment is we really should be looking at treating the cause and not the symptom. So I'm certainly a haematologist, and I know most of my colleagues here believe that if somebody needs treatment for their Waldenström's lymphoma, chemotherapy is the important bit of the treatment. And plasma exchange is a secondary form of treatment because the chemotherapy directly attacks and kills the lymphoma cells, whereas all plasma exchange does, it helps lower the protein, but it actually doesn't have any underlying effect on the disease that is in the bone marrow producing the protein. And again, it's not to say that plasma exchange isn't important, because in fact for many people it has a very important role to play, particularly if the protein levels are very high and there is a risk of hyperviscosity. Then plasma exchange is the best treatment for getting that protein level down very quickly while the chemotherapy is started and it starts to have its effect. And as I mentioned before, that strange effect from rituximab where it can increase the protein very quickly during the first few cycles, plasma exchange can be also very useful to help guard against that. So sometimes we use plasma exchange in combination with the treatment, but the chemotherapy itself is probably, from my perspective, the most important thing. All right, well that's really, we've come to the end of the talk. So.
Thank you, Jason Butler, for presenting our webinar, and thanks everyone for attending. You'll get a link to watch this again within a day or two. So thanks very much.